Morning to everybody in Boker Tov. Thank you for joining us. You've all joined in on mute. We will be able to have questions. You can type them in the bottom of your screen. Most of us, thanks to the current times, are all too familiar with Zoom. But at the bottom of your screen, you have a chat feature. Since we have 45 people on now and we're expecting a lot more, you'll see that there's a place where you can send a message to everyone. So thank you, Abby. We just got your message. And it is going to last until 10 o'clock. So we're about 45 minutes. You can also send a chat individually, either to myself. My name is Carmi Soder, and I am the new chairwoman for mHealth Israel. Thanks to Levi Shapiro and all of his wonderful work with mHealth. He's done an amazing job. He has about 7,000 members, 35% of whom are women. And the flexibility, Esti, for our morning breakfast in person that we were so excited about is now a webinar, but I'm convinced that one day we'll be able to do it. So Esti Shelly, we are very fortunate to have. She is the Director of Digital Health at the Ministry of Health in Israel. She has got her master's from Hebrew University and also a master's in public administration from Harvard. Let me see if I can mute everybody who's joined. But I think most importantly, her ideal diet would be one of coffee and chocolate, which sounds to me like the perfect combination. But I think it's great to kind of get to know each other. I've really enjoyed speaking with you, Esti, and getting to know you, and excited for what you have to tell us. So Esti will be speaking for about 15-20 minutes. I'll kind of group the questions for her, and then we'll have Lital joining us about 9:35. So go ahead. Good morning. Thanks, Esti.
Good morning, everyone. Thank you very much, Carney. And I will try to share with you some more questions than answers, but to give you our perspective in the Ministry of Health, how we look on what's happened and how we prepare for telemedicine in the time of the COVID-19 pandemic. So we are like in the middle of the perfect storm. This is actually a slide that I was using like in all my presentations of why we need digital transformation in healthcare. And now we add to aging population and the increase in chronic morbidity and the increase in prices of medical technologies and consumerism that we see. Now we have also the coronavirus. So that gives us like really the perfect storm where we all now already for 3 months in it. So what happened in Israel during, we call it the first term of COVID-19. In March and April, we saw that most of the Kupot Cholim, the HMO's primary care clinics were actually mostly empty. The specialty clinics were closed or empty. People didn't show up for meetings, and the ambulatory care in the hospital was closed. So what was happening that the COVID-19 patients that were at home or at hotels really get high attention from the medical staff. We had a special app to monitor, to self-report, to have video calls and alerts with those patients. And the rest of the patients in Israel, they got all kinds of different telemedicine services, from phone calls to videos, chat, email with their physician. But mostly we saw a huge decrease in demand, which is, of course, very dangerous when we're talking about high-risk patients. But now we are in a different stage. In some way, we are kind of back to normal. We're back to normal. So we see the primary care clinics are totally full. The ambulatory care in hospitals is open. And we see increased demand for COVID-19 tests and, of course, huge increase in COVID-19 patients at home. Currently, the number is about 20,000 patients that are staying at home or at hotels. And we need to monitor and to manage them clinically when they're at home. And on the other hand, we still have all those high-risk patients that during March and April, they were able to postpone some of their visits or some of their questions and needs, but now we are talking about much longer term. So we need to see how we are dealing with this. And this is a challenge for the whole healthcare system. So one sentence that we actually working according from the first day of the COVID-19 pandemic is never let a good crisis to go to waste. So we are trying to see how we can make a lemonade from this lemon. And we are looking on what happened in Israel. We had actually a large scale experiment in this short time. During March and April, what we saw is it's like a huge natural clinical trial that we had in Israel. People were using telemedicine services really widely. Physicians that before that it was very, very difficult to convince them to move to telemedicine. They were all in. So questions that we are asking ourselves after when we are looking on this large scale experiment is what we can learn from it. Okay, we had this experiment. What works better, what didn't work? We saw, for example, that many people preferred to talk on the phone, not a video chat like we are doing now, to talk on the phone with their physicians instead of video chat because they weren't feeling very comfortable, sharing their home background. And some of them prefer to chat or email with their physician. What kind of groups didn't feel comfortable to do or didn't feel confident to use telemedicine services? We see that Arab Israeli population didn't use much telemedicine services. They were still preferring to come to the clinics instead of calling or, of course, using video chats. And this is a population, for example, that are using smartphones and have access to the internet. It's not like the ultra-Orthodox community in Israel. And on the other hand, the ultra-Orthodox community, which you would expect, they won't use telemedicine services because, of course, they are not using technology, etc. We saw that they were using a lot of phone calls, visits. And another aspect, okay, we had all kinds of solutions for, we call it like emergency times. But what is the best clinical practice look like when we're talking about telemedicine services? How we can make the most of the remote visit, how we can make sure what was happening before the coronavirus pandemic, that when a physician was doing a telemedicine or a televisit, if he couldn't check the patient, if it was a more complex situation, he was just asking the patient, okay, come to the clinic and I will check you. And when you're trying to do it mostly remote, then you need to find all kinds of devices and all kinds of different models of services so you can make the most of the remote visit. How we can be better prepared for the winter, this is what we are working really, really hard right now. How we can be more inclusive to make sure that we won't forget all kinds of groups in our society to stay out, how we can make it accessible for elderly patients, how we can make it accessible for Arabs and ultra-Orthodox and all other groups in Israel. And not less important, how we can make it easier for the physicians. If for them it's very, very complex or very hard transition, then they would prefer that the patient will come to the clinic. And we don't want them. We want them to stay home. We don't want them to be exposed probably to infection. And how we can use those services to minimize disparities and not increase the disparities in access to healthcare services. And the last one that we are asking is, again, how to enhance the change and how we can make sure it's here to stay. Now everyone understands the coronavirus is here to stay, but at least for the next year or two. But we want to make sure that the transition that we see in healthcare services, that they become more digital and we can do more telemedicine services, we want to make sure it's good enough medical services. It's not just for, you know, all kinds of administrative services, and how we can make sure it's here to stay. It's part from the medical education, and it's part from the medical services that we are giving in Israel. So I'm asking a lot of questions, and just to give you a sense of how we are dealing with all those questions, this is like a generic slide for how we are doing digital health transformation. So we are the ministry, we are not giving healthcare services. We are just the regulator or just the headquarters of the Ministry of Health. We are not providing the services. The services are provided by healthcare organizations like Kupot Cholim or hospitals. So we are usually doing combined interventions in all those aspects. First one is, it's from right to left, sorry. First one is learning. We need to have like continuous learning in terms so we can see how we enhance the transformation. If we will stay in place and there won't be like mutual learning in the medical community around what are the digital health transformation, it won't last. We need to adjust the regulation many, many times. We see that the regulation is behind digital transformation, and especially technology. The third aspect is sometimes we actually need to provide or to support the technologies that need to be in place. And the fourth one is we need to support acceleration. We as a government cannot do everything. I cannot be like the bottleneck for digital health transformation. So who can actually do the digital health transformation? This is the health organizations mostly. Of course, with all kinds of collaborations and pilots, etc., with the industry, but we are supporting financially and with other programs, acceleration of digital health transformation in the health organizations. So what we are doing in terms of telemedicine, so we are starting very, very soon. You will probably see it online like in a week or two. Public participation process to hear and to learn from patients and personnel what was their experience look like, what worked for them, what's not, and trying to see how we can learn and have insights from these huge experiments that we saw in Israel. When we start this process of building this public participation, we designed it, said, okay, now that the corona is over, tell us what happened. And now we are just rephrasing everything, but that's the small problem of what's happening now. And we are now starting a telemedicine professional network. It's a platform for mutual learning for professionals in the Israeli health organizations. And that's a very interesting initiative that we are doing with MoH and in BAR program, which I'm a member of. And we are giving, of course, regulatory support and doing all kinds of adjustments. Hopefully, if the budget will pass in a way in the coming future. It was supposed to be last week, and I hope it will be by next week. But we are planning to launch a very large-scale program to support development of telemedicine services in the healthcare organizations in Israel. And it will also support home hospitalization programs, something that's supposed to be like in a very large scale, definitely compared to what we had until now, in a way that can support the developing and the building the infrastructure in the health organizations to make sure it can go in scale for the next winter and the years to come, and not just like a short-term solution to deal with the COVID-19 pandemic. And a lot of training and education that we are supporting. For example, adjustment that we did with nursing schools to their program to see how we can teach from the basic education of different professions, how we can, because think about medical school, no one teach a physician or a physician-to-be how to give care through telemedicine services. Everyone is talking about touching the patient, talking about looking them in the eyes, but how we can teach them and train them to give this kind of services when they need to give them remotely, and to make sure it's significant enough. Because it's not just, we are really, telemedicine will become a platform just to take care of all the administrative issues. Okay, we don't want telemedicine to be a solution for administrative visits. We want to make sure that in telemedicine you actually can give medical services. I'll stop now for questions. So please feel free, and Carmi, I count on you to lead the questions session.
Yeah, absolutely. So we have a wonderful group from Hadassah Hospital that's joined us. I just want to let everybody know we have 88 people on the call this morning. So thank you all for having your coffee with us and joining us. One of the questions was about which professionals are going to be included in this initiative, specifically asking around nurse practitioners, and if they plan on being part of this plan.
So we are not talking about physicians only. In everything we are doing, we're talking about all kinds of professionals that give different healthcare services. It can be from, of course, nurses. It can be even speech therapies and physical therapy that we are seeing that can give all kinds of telemedicine services. If they are giving healthcare services physically, they can give it in tele.
Yeah, I'm moving it at home. It is interesting. I don't know how many people on the call have done telemedicine themselves. It's an interesting experience to use. So I think it's great, Esti, that it's really being looked at what kind of lessons have been learned through this unbelievable, unprecedented experience that everybody in the world has been through, and what kind of things can we learn from it and gain and improve. It's been interesting to see the different cultures and ages and people that adapt to telemedicine. Have you seen, Esti, that there's a group that is more kind of willing to be an early adopter and utilize telemedicine more so? I know you pointed out some that don't. Have you seen or gotten feedback? Mm-hmm.
I talked a little bit about the ultra-Orthodox. It's very interesting to see that they don't have, let's say, a real barrier to use the telemedicine services. Of course, there is some technology barrier, but they are really okay with talking with their physician or their nutrition guide on the phone. They're really fine with that, which was very interesting to see the numbers. We look on the numbers from the Kupot Cholim, the HMOs. It was quite amazing. They are not using video, but they definitely use phone calls, and you didn't see decrease in visits when you give them the ability to use the phone. I think it's a very interesting group that you would expect to have to be like very late adopters of services, but they are not.
And it's nice that you can have it at a different level. I know when I call my family back in the US, some will do video chat always and others would never. So it's interesting to see how you can adapt technology and do to different levels. So there was a question about, as the Ministry of Health, are you going to be involved in a telemedicine healthcare startup?
If we are going to be involved in the startups,
yeah.
We are supporting in different programs with the Innovation Authority, supporting pilots in health organizations in Israel. Most of them are different kind of telemedicine services, means using devices and sensors, etc. Traditionally, the Ministry of Health is not supporting the industry directly, only through the Innovation Authority. We are supporting sometimes the health organizations that are doing all kinds of models with the industry.
Right. And that's very similar. One person asked a very specific question. So some people I'll follow up with you privately after. There is conversation about facilitating collaboration. So if anybody wants to have a collaboration or discussion, feel free to reach out to me. I'll be sure and post my information. The best way is, I can guarantee you I'm the only Carmi Soder on LinkedIn. I'm pretty active on LinkedIn, so that's probably the best place to find me. I'm meant to be in Israel since there's a town that I'm named after here. There's also a question about data and the role of implementing telemedicine and digital health, and if there's any plans to leverage the data collected for research.
Oh, definitely. That's a whole different presentation that I can give about how we are supporting data for research and for R&D in general. We are calling it like it's a secondary use of clinical data, and I think it's a very interesting segue to Tali that we'll show in a second.
Perfect. I think that's the perfect segue. We can move to Lital. Thank you very much, Esti. You generated a lot of questions, and again, I'll follow up with everybody for the questions. So thank you very much, Esti. Wonderful. Thank you. So our next speaker is Lital Keinan-Boker. She is the director at the Israel Center for Disease Control. She has her MD and PhD, and she's been at the ICDC for 17 years. She's been, additionally to Esti, very busy these days. So thank you very much for joining us and to us. And we will have you share your information. And I think we're going to unmute you, or Lital, you can unmute yourself, and welcome.
I just did.
Perfect. Good timing.
I also shared my screen. Can you see this?
We can. Thank you.
Very good. Lots of technical problems on the way, but I'm glad you can see that, and thank you for inviting me. So I'll talk a little bit on a different aspect. I'll talk a little bit about what the Israeli CDC was doing during this, and still is doing during this Corona days. And I think I'll just start with a few words on the coronavirus, which you probably all know. A new thing that came into our lives around December 2019. I think not many people thought it'll affect us then, but it sure did, and it still does. So here we are now with over 13 million people affected all around the world and over 500,000 deaths. And Israel, which started very well and had a good month of May with very little cases, is actually now escalating, and we see, I'm not sure you can call it a second wave, but we sure see a lot of new cases. I have to say a few words about the Israel Center for Disease Control, because despite the similarity in the name, it is not the American CDC, and not only because of the size. It was established only 25 years ago in the Ministry of Health. So this is one big difference. We are a unit in the Ministry of Health, while the CDC is a federal institute. And we were actually focused on providing decision makers at the ministry with valid data and health issues. And we were also supposed to bridge information gaps that were found in order to make things easier, in order to make evidence-based decisions, which are related to public health. So we collect information through many ways. We do surveys, both telephonic and face-to-face, not so much face-to-face interviews now. We do seroepidemiological studies. We build disease registries. We publish health publications. We do surveillance of unusual morbidity. Usually it means that we do the surveillance of the influenza season. But our focus is mainly on non-communicable diseases, because when the CDC, the Israel CDC, was established, there was already the Department of Epidemiology at the Ministry of Health and the Public Health Services, which mostly dealt with infectious diseases. So, so this is another big difference between us and the American CDC. But we do have some things to do around these Corona days. And I just want to tell you a little bit of our main activities, which is a little bit different from what Esti is doing, because we're actually using the data collected both in the Ministry of Health and elsewhere to just give probably decision makers some evidence in order to make good decisions. The first thing we were doing was a call center. Then we started our COVID-19 surveillance. It was based on the existing influenza surveillance system that we ran already for 15 years. We also looked at respiratory syndrome clusters. We collaborated with the Tel Aviv University on a serological testing in order to find how many people have met the virus ever since February. And recently we built a COVID-19 patient registry. I'll tell you a little bit about each of these activities. I'll start with the call center because this was the first thing we did. And actually it's written on the National Pandemic Plan, which unfortunately was written in 2007, and it has to be updated. I think it is being updated now, but we were using it at the beginning of outbreak. We were supposed to establish a call center dedicated to queries from health professionals. It proved to be a very helpful thing to people mostly from healthcare funds, also hospitals, which had many queries and questions because of the changing guidelines. It was rapidly changing all the recommendations and guidelines and definitions. And it was very handy to have our phone number, and we ran this call center for 15 weeks, during which we got over 6,000 calls. And I'll just want to show you a little bit an interesting graph that we have here. The blue blocks are the number of calls per day. So of course you see that on Saturdays we were not working, and on Fridays the calls were less than. Also the healthcare funds are working less hours. But funnily enough, most of the calls we got even before the first case was diagnosed in Israel. And that's because all the preparations actually requested for a lot of new recommendations and guidelines, and this caused a lot of chaos. And this is why most of our calls were even before the morbidity starting to go up. The yellow line here is the number of cases diagnosed. We closed it in May because there were very little cases by then. We did not open it again. But this was, I think, very helpful at the time. Another thing that we did was trying to convert our surveillance for influenza into a Corona-19 surveillance system. Our system for influenza surveillance, as I said, is working for over 15 years now. And it's based, first of all and primarily on data from primary care visits to the two main HMOs in Israel, Maccabi and Clalit. So it probably covers around 80% or even more of the population. And we can sort out which of these visits daily, on a daily basis, were due to respiratory syndromes or influenza-like illness or pneumonia, etc. The next level is information from the Clalit hospitals, where we get ER referrals, emergency room referrals for pneumonia or other respiratory syndromes, both for children and adults. The next level would be mortality, general and pneumonia, and this is national data. And then we get also laboratory data, both from hospitals, from two hospitals, Sheba and Rambam, and also from 48 primary care clinics, which we call centers. They send samples, nasopharyngeal samples, swabs of patients that answer the criteria for influenza-like illness. And so we can validate what we see in this level, the largest one and the most valid one. But we can say that people approaching their primary clinics with influenza-like illnesses at this time of the year probably have influenza because we sampled them and around 50% of them do have influenza. So this is how it works. It took a lot of time to build it, of course, but it's working very well. But now we had some challenges when we try to convert this system into a COVID-19 surveillance system. First of all, it's not seasonal. It's gonna be all year round because it's summer and COVID-19 is here. So we had to run it longer than usual. Second, we had a lot of problems with visits to primary care units because people just avoided going there. And not only because they were afraid of being infected when they are at the clinic, but also because there were specific guidelines asking them not to go to the clinic if they have fever and they cough. And of course, because of the lockdown too. So this was not as valid as we hoped for. And again, it was the same with the ER visits, emergency rooms visits. And we had problems also from the lab sampling in hospitals, because usually we did it from certain patients that answered some criteria, which we call SARI, severe acute respiratory illness. But they were not treated normally, but they were transferred to corona departments, which of course at that time did not take part in the surveillance. They did not have time for that. So we had no samples from hospitals. And also the sentinels that we always rely on to validate our data also had some problems, not only because of the low visits rate, but also because the team there needed now personal protective equipment in order to take the samples, which usually is not the case for influenza. So we had to provide them with it. We had to provide them with the kits, and there was lack of kits at sometimes and lack of reagents. So a lot of challenges. But I think we did manage, and we do follow more or less the general picture. I'll just show you what we found here. This line here, the solid line, shows you the positive swabs that we got in our sentinels, while the dotted line here shows you the positive swabs from the general population. And of course, it's not as sensitive as we'd hoped for, but it does follow very well what is going on in the general population despite these challenges. So we keep on doing this surveillance and we'll continue into the winter, and then we'll have to do a dual surveillance, both influenza and corona. Another thing that we did was respiratory syndrome clusters. And again, we took the data from that, from the files that we get daily from the two HMOs that I mentioned. And we just do geocoding of addresses in order to see whether there is a cluster of respiratory syndromes in some part of Israel. And just to show you, this is a cluster that we keep on seeing in Rahat. That's a Bedouin settlement in the south of Israel. And what we see is that the start of this cluster means that the morbidity there is higher than expected. So it started already in June. It goes on for 24 days already. Every day it is higher than expected. And we also know now that the number of COVID-19 cases that were diagnosed during this period was 191. And this gives us a good idea of these clusters, how good they are with predicting coronavirus disease. Another thing is the serology testing that we did. We used a resource that we have for that. We have a sera bank. In this bank, we collect blood samples that were supposed to be thrown away after the examination, the tests were done on it. We get it both from the blood bank, which mostly represent healthy people that are donating blood, but we also get it from some community laboratories of several HMOs. And by now we have over 130,000 samples in our bank. For this research, which we collaborated with Danny Cohen from the University of Tel Aviv, we took samples that were collected in March and April in order to see how many people in Israel actually have antibodies for coronavirus, because when we use the PCR, the usual swabs, we only know whether a person is sick now, but we don't know whether a person was sick before. And for that, we need to know whether they developed antibodies to the COVID-19, to coronavirus. And that's what we did here. These are the results that we had. In total, we had 1,700 samples. It's not very much, but of course, we only took for 2 months, March and April, so it's not very much. And we saw that around 3.8% of the population had antibodies, but since we know that there are some limitations to the kits that we used, we also did some sensitivity analysis, and we are quite sure to say that around between 2 and 3% of the population were already exposed to the virus, whether they were known cases or unknown cases. And this is said to the period by the end of April. So I think it's a very important information for the management of this pandemic. The last thing I'll mention is the registry. We do have a lot of disease registries, mostly chronic diseases registries, such as the cancer registry or stroke registry or diabetes registry. But we were asked also to build a registry of patients with COVID-19 that were diagnosed in Israel. And the legal framework that we can work within is actually that the COVID-19 is declared as a reportable and a dangerous disease. So people have to, institutes, HMOs, etc., have to report to the MoH about this disease. So this is the legal framework. And the current status of this registry is that it's partially built, and I'll explain why. It's actually very, very difficult. We're talking about data and digital data, etc., but it's not easy to get. So we planned this registry to be built of 3 components, the MoH data, the Ministry of Health data, and this is not one data set, but actually several, because we have the COVID-19 testing results, but we also have the patient isolation data. We also have epidemiological investigation in it. We had to harmonize all these data sets and of course, to clear the data, to take off all kinds of duplicates and to fill in what is missing, etc. But this part we do have because, you know, it's within house. We're part of the Ministry of Health. Not that it was easy to get access to it, but we did eventually. But we do plan 2 other components and we still don't have them. And they're essential in order to really study the disease. And this is the HMO data on, for example, background morbidity or smoking or obesity, and also hospital data of those that were hospitalized. What was going on during the hospitalization, what medications they got, what was the reaction, side effects, etc. And this we still do not have. But we can do a little bit with what we have. I'll just show you a few slides and then I'll finish. This is just the number of active cases. It's basically is going on and on. Here we stopped at the beginning of last week. We can tell you that we see some differences in the patients that are diagnosed now. The blue blocks here are the number of patients. So you see the month of May and you see the escalation in June, but the red line here is the percent of patients that are diagnosed because of symptoms. And this is going down. So we see more and more asymptomatic patients diagnosed now, and we have not seen them before. So this makes the mix of patients now a bit different. We also see a difference in their ages. I won't go into it because it's full of colors and I think too many age groups. I can only tell you that we have younger patients now, and these graphs show it. It goes one of them for each month until June. And also, if we look at those that are categorized as the hospitalized patients categorized as severe cases, we do see a difference also in their age distribution, and they're younger now in June as opposed to March and April. The last thing I'll show you is what we see here, the chances of a hospitalized patient to deteriorate and be categorized as a moderate or severe case or even being ventilated. We also see lower percent of these here in the two younger age groups, those under 60 and those up to 70, in the period of up to the end of April, and then again during June and July, but no differences in the older people. So we do see the impact of having younger patients, but if an older patient is diagnosed now with coronavirus, then we see the same results more or less, or the same rate of deterioration. That's all for now. That's all I wanted to show you about what we do, and open for questions.
Very interesting. Thank you, Lital. That's amazing. A lot of great information and quite a few tidbits that have generated questions and a lot of interesting things learned there. One of the questions was around, I guess, some of the public data that has been released has not included sex or gender. Do you know?
Oh, we do. I just did not present it.
Oh, okay. Got it. Great. Good to know. And then there was a question around collaborating between public and private research and the best way to collaborate.
Well, there are two ways, actually. I think Esti can help you with the TeamNap project, because this is one good way to collaborate with the data in the Ministry of Health. It's a data pool, and there are virtual study rooms. You can apply for data also on the coronavirus. Exactly what I showed you now is also available in the TeamNap project. And so you don't need to collaborate with me. You can do it directly through this project. But on other things, because I mentioned also other disease registries, we usually get applications, and we do collaborate with private researchers, with academics, etc.
That's great. That's great. There were some questions about testing blood samples and testing the blood samples, kind of how people are notified, and questions about the blood sample testing.
Do you mean those that we collect for the Sera bank that
yes.
we have? Well,
I believe so.
Yes. Well, it's anonymous. It's anonymous samples. We don't know who the person is. We only get it with the notification of gender, age, and the area in Israel where they come from. So we need to get permission for that.
Great. Great.
So instead of throwing it away, we get it to the bank.
Perfect. The other thing I wanted to let everybody know is that these presentations will be published in the LinkedIn mHealth community. So if you're not a part of that, please join that. It's also a place, if you haven't gotten your questions answered, you have other questions. There's a lot of questions coming in now that I'm trying to read through. So I just wanted to let you know, feel free to reach out to me, and I'm happy to facilitate getting some answers. I really want to thank you both, Esti and Lital. This is very informative as we find ourselves, many of us, I can tell by our backgrounds, in our homes again. I was going to make a joke about being mask ready, and even though we were on a webinar, we should all have our masks with us at all times. I think I'm going to invent something where I could wear it as a hat or a purse. I'm not exactly sure what it could be, but I really appreciate it. And thank you all to join us. We had about 90 people joining us. So obviously it's really an important discussion. And I'm really proud to be part of mHealth and represent mHealth Women. Look forward to a lot more webinars. If anybody has speaker suggestions or topics or ideas, hey, please send them my way. We hope to do a lot of this. So it's a great thing. Start the day. Thank you again, Esti, Lital, very informative, and for all the great work you're doing. Woohoo! Keep it up. Powerful women. I love it. Great being in Israel. Thank you so much for all you do.
Have a good day.
I feel very safe here. Take care.
Thank you so much. Have a great day.
Thank you, everybody. Wear your masks. Ta-da, ta-da.